Okay, so we're going to talk a little bit about pharmacokinetics of the different opioids and their tolerance. So the pharmacokinetics is going to be the main thing that differentiates different opiates, so it's a pretty important thing to consider. They're all going to have fairly similar pharmacodynamic actions, which is as an agonist on different opioid receptors, mostly mu for the ones that are used recreationally, but the pharmacokinetics are going to make the difference. So, for medical administration, it's usually either given orally, basically like when you're prescribed oxycodone when you have a chronic pain issue. Let's say you got ACL surgery or you got your wisdom teeth out. That would be a oral administration. It's less effective because you have a slow absorption and there's a significant first pass metabolism effect, meaning that you lose a significant amount of the potency. But you can have a constant and consistent blood level of the drug within your bloodstream, which is usually what we're looking for with medicinal administration. If you need something that is more rapid onset, it can be given intramuscularly, transdermally, intravenously. So if you, for example, get in a car accident and need immediate injection, you'll most likely get an intramuscular injection. Transdermal is usually coming through the form of fentanyl patches given post-surgically. Epidural, as I'm sure many people know, is when it's sent directly into your CSF, usually through your spine. This is often used mostly in labor pain so that you can block pain from the point in the spine where you inject down instead of your whole body. And then intravenously is going to be what you would get in an IV if you were having a long-term hospital stay. Okay. When it is used recreationally, it can be inhaled, it can be smoked. This is often referred to as chasing the dragon. It can be taken intranasally or snorted. You can use an IV injection or a subcutaneous injection. The problem here is that you need to be able to safely prepare and administer the drug. If you inject it in the wrong place, for example, if you hit an artery instead of a vein, you can have significant medical complications. So while it will be an intense high that hits you for a long time and you'll get the maximum effect for the dose that you give, there are significant downsides to it. Absorption is going to vary based on the route of administration and the type of opioid. Remember, some of the differences between the different opioids we talked about is lipid solubility, and that's going to have a huge effect on absorption. So it can readily pass, most opioids can readily pass any barrier, so it can readily pass the placental barrier, which can cause premature birth and low birth weight. Children who have been exposed to opioids in the womb will be born with an opioid addiction, and they will show withdrawal symptoms immediately. Most opioids are fairly slow getting through the blood-brain barrier. The exception for this is heroin and fentanyl. This is why an epidural is going to be much more fast onset, right? Because we're bypassing the blood-brain barrier, going directly into the CSF. Heroin and fentanyl have such a high lipid solubility that the blood-brain barrier is not as effective as keeping them out. The brain has an active transport system to eliminate opiates. So this is going to be a similar way to the way that opioids are metabolized, and the levels of them are regulated within the brain. So opiates are going to be utilizing the same family of proteins to be transported as endogenous opioids as well. The brain has lower levels of opioids than the rest of the body. So we can see, if you look in like the gut, you're going to see a high level of opioids. Metabolism is going to occur both in the brain and in the liver. Heroin is going to be converted by enzymes into the brain into morphine. So heroin and morphine do not interact differently with opioid receptors. In the form of heroin, it can get to the brain much more quickly, but then once it is in the brain, it will be converted to morphine. So the only opioid that really acts on the brain is morphine. Heroin, codeine, fentanyl, all of these are going to be changed into morphine before they have their psychoactive effects. So morphine is mostly metabolized in the liver. All of the others are mostly can be metabolized in the liver or the brain. Codeine is also going to be shifted to morphine. Both morphine and codeine have active metabolites. So even though once morphine has been metabolized by the liver, it can still continue to have psychoactive effects, which means that it's going to be longer lasting. So one of the one of the many chronic effects of opioid use is going to be tolerance. Tolerance to analgesia, the pain-killing effect, the euphoria, and the nausea occur rapidly. You may have been prescribed Vicodin or oxycodone at some point in your life for a medical reason. A lot of people say that when they take it, they feel very nauseous. This is a really common effect, but if you continue to take the drug, that side effect usually will go away with the tolerance. But unfortunately, the pain-killing effect will also go away, and you'll need a higher dose. Minimal tolerance will develop to the constipation, respiratory depression, so that slowing of your breathing, and the pinpoint pupils. So you can increase your tolerance to the respiratory depression, which means you can take a larger dose without overdosing. However, the tolerance to that is going to take much longer to build. One of the theories behind opioid tolerance is levels of cyclic AMP. So one of the things that opioids do is inhibit adenylyl cyclase. So when you begin a morphine treatment, we should see a drop in normal levels of cyclic AMP, and that is what we see. However, as you continue to use it, you start to build a tolerance, and those levels of cyclic AMP normalize to compensate for the presence of the morphine treatment. Then you're going to, once that is stabilized, you have now formed a physical dependence, so that when you remove the morphine, when you withdraw it, you're going to experience a significant withdrawal. So when you remove the morphine, those cyclic AMP levels really skyrocket as a sort of compensatory springback effect after having been depressed for such a long time through the effects of the morphine. As those cyclic AMP levels stabilize, you will experience withdrawal. Once you have stabilized back to your normal level of cyclic AMP, you should no longer be experiencing acute withdrawal symptoms. You may experience more long-term withdrawal symptoms such as depression, but the acute ones of sweating or pain should not be as intense. Okay? Opioids also show cross-tolerance. Any opioid is going to affect all other opioids. So if you are a chronic heroin user and you have a legitimate pain problem, the dose of morphine required in hospital to treat that pain problem is going to be significantly higher from somebody who does not regularly use opioids. There's also going to be a functional tolerance, what we refer to as a pharmacodynamic tolerance. There is a decrease in desensitized opioid receptors, so that they're going to be downregulated. There's going to be less of them expressed. Additionally, the ones that are expressed are not going to be as effective. They will still interact with GIOs, but they're also more likely to interact with beta-arrestin, and they're less likely to recruit a GIO to have their effect than previously. Metabolic tolerance is also happening by adding more enzymes in the brain and in the liver. So all of these are all different mechanisms behind opioid tolerance. So as you can see, these multiple mechanisms are going to converge to create tolerance very quickly. Most likely this is intuitive, but just in case, I want to make it clear that opioids establish both physical and psychological dependence. There is a functional tolerance in that, and the compensatory actions of cyclic AMP are going to cause the withdrawal symptoms that we see. If we have withdrawal, we must have physical dependence. You can also have cross-dependence. So, for example, if you have a dependence on OxyContin, you were originally prescribed it, but you started using it in a way that was not in keeping with the dosage that was described. You start taking it more often or in larger doses, but then your prescription runs out. And you went into withdrawal, that withdrawal could be mitigated by taking heroin. So if you use any other opioid, you can mitigate the withdrawal symptoms that you were experiencing from stopping the use of the other opioid. This is also what's causing people to do that large overdose of loperamide. They've usually been using heroin and can't get it. Loperamide will still help with the withdrawal symptoms because there's a cross-dependence there. The psychological dependence, people will continue to use it despite negative consequence of use. They don't know how to feel good without it. Both of those are very clear with opioids. And the tolerance is all coming from the way that we know tolerance comes from, and dependence, where you have a homeostasis, you use a drug which is disturbing the homeostasis. The brain is going to compensate for the continued presence of the drug to build a new homeostasis. This is when we're seeing dependence. When you remove those drugs, but the compensatory mechanism is still in place, you're going to have a disturbed homeostasis, which is where we see withdrawal. Remember, each one of these steps is associated with a specific level of cyclic AMP within the cell. So that is it for pharmacokinetics and tolerance. Next, we're going to talk about opioid addiction and treatment.